Good day, my dear students. Welcome to R.A.T.S for PGs. The topic for the day is female infertility. It is a complex topic that cuts across several disciplines, starting from anatomy up to gynecology, including endocrinology, as well as several ethical issues and forensic medicine. In fact, the definitions are important in the court of law. Primary infertility is a term that is used when a woman is unable to ever bear a child. Secondary infertility, on the contrary, is she has been pregnant earlier, but then failure to achieve a live birth after having given a live birth previously. So these are two different terms which we shall keep in the corner of our mind. This is a diagram just for recapitulation. And see that it is superimposed on this. This is the development of the female genital tract. There is a urogenital sinus or a ridge that is formed over here. Initially, you find that it is a solid column which undergoes a canalization, as you are seeing over here. Simultaneously, you find that there is a bifurcation in the form of a Y, which gets almost pear-shaped in outline, forming the uterus. Also, you find there is a oviduct and the ovary that develops in it. There is a canal that connects the cervix and the vagina. Why this is important is, if there is going to be a defect in any of this, there can be an infertility. For example, a vaginal septum, or it can be atresia of the ducts, so on and so forth, which you can mention. This we have already seen. This particular diagram is again of importance to us. We are actually bisexual earlier on, but then both the ducts are there, of which one becomes indistinct and the other becomes patent and obvious. In the male over here, I find that the Wolffian duct is persistent, whereas the Mullerian duct becomes degenerated. On the contrary, in the female, you find that the Mullerian duct is patent, whereas the Wolffian duct becomes degenerated. Other things we'll forget for the time being. So there's a uterus in the canal, which is constant. So I would like you people to kindly compare with this. So coming to the terms, you find that it is always a central cause, a local cause, and a secondary cause that can cause infertility. There can be tumors. There can be other syndromes which are associated with it. There can be hormones, and it can be either pathology or physiology or pathophysiology. This definition is slightly different. Infertility is related to a couple and not to the individual. They fail to achieve a pregnancy after 12 months of regular unprotected coitus. Subfertility is any form of reduced fertility with prolonged time of unwanted non-conception. So these are two different terms and of great medico-legal importance. Fecundability, probability of achieving a pregnancy within one menstrual cycle. And fecundity, probability of achieving a live birth within a single cycle. So these are terms which are probably important to the lower creatures and not the human being of today. A beautiful line diagram for recollection. You have been seeing this day in and day out and making the diagnosis. The medulla, the cortex, primary follicle, secondary follicle, tertiary follicle, which becomes arteritic later on. If it persists, you find that there is a pre-ovulatory follicle, and finally the egg is being released. There is a remnant of it which is formed, the corpus luteum, then the corpus albicans. And in the physiology of the female, you find that in the early ages, they are subfertile. Then there is a sterility. Then there can be a cyclical irregularity. There can be a menopause. These are all the various problems in the fertility. You cannot expect a 14-year-old girl to become pregnant. Also, you find that progressively there is a decreased chance of becoming so. The ovarian follicle, we all know. And this is a picture that is taken from the Gray's anatomy. Externally, there is a fibrovascular core. There is a granulosa layer over here. And this is the germinal vesicle surrounded by a capsule or the zona striata. And there is a disc that connects it. Discus proligerus. The same thing is being reflected in this diagram thanks to Gray's anatomy over here. These are the granulosa cells, the membrane granulosa, and this is the pedicle or the stalk, the cumulus oophorus. The corona radiata is over here, which is mentioned in this diagram. And the zona pellucidata are the clear zone that is seen in this. So these you people have in mind. This is a very important diagram which we fail to see nowadays, the normal menstrual cycle. Nowadays, you do not see the proliferative phase, secretory phase, etc. There is always a disordered proliferation. Initially, you find that there is a peak in the estrogen. This is followed by a peak in the progesterone. And subsequently, you find that there is a development and finally the corpus luteum and the corpus albicans. Another set of hormones which are important will be the follicle stimulating hormone and the luteinizing hormone. So you find that these are the normal values which you people shall and definitely incorporate in your answer on female infertility. The disorders of ovulation can be divided into oligo-ovulation, which is irregular, anovulation, which is absence, irregular cycles, which we see regularly, secondary amenorrhea, excessive bleeding, again always seen in the OBG request form. And any of the menstrual disorders can always indicate an underlying ovulatory disorder. This is another form which is very important. Hope we memorize this. There is a WHO group 1, WHO classification as mentioned. Group 1, it is restricted to hypothalamic, pituitary and the gonadal axis. So there is a failure of the axis. Group 2 is hypothalamic, pituitary and gonadal axis dysfunction. Mostly it is a case of polycystic ovary syndrome. Group 3 is restricted to the ovarian failure and group 4 is hyperprolactinemia. So these are the 4 groups of WHO classifications which you people should know. This is a very important axis as I had mentioned. The infertility can be a problem of the ovary or the female genital tract, or it can be a problem of the hypothalamus pituitary ovary downwards to the uterus. And the hormones are gonadotropin releasing hormone, follicle stimulating and the luteinizing hormone, estrogen, progesterone, and the feedback over here. So it is very important to analyze where exactly things have gone wrong. Memorize this. A beautiful line diagram, which I would like you people to leisurely see and draw. Don't explain the wonders of colors to a colorblind. The polycystic ovary, you find that these are the syndromes, a study that has been conducted on the students, and you find that various factors can be over here. The problem with the polycystic ovary is there can be ovulation induction or there can be a ovulation suppression. Both are probable. And this is a list of symptoms and signs. See what you can find in your patient. This is the ultrasound picture wherein I am finding a normal ovary and then multiple small follicles, polycystic, which finally become arteritic. The same thing is reflected in a color MRI over here. And these are all the underlying disorders which you'll have to correlate. Always we do ask, whenever there is an endometrial biopsy or an ovarian one, what is the history in the patient? And this entire group we people shall and will think of. Please memorize it. The polycystic ovary, these are all the symptoms over here, and this is the mode of treatment that is over here. And the other things that have been formed as a modality of treatment, kindly go through for completion. The arteritic follicle that I have mentioned, you find that there are multiple ovarian follicles which are being formed when the lady becomes or attains menarche. After which you find that there is a progressive, massive increase in the number of follicle formation. That is why fertility is encouraged before the age of 30 years of age. Bearing a child rather. So these are the primary follicles. Finally, you find they can become arteritic. There are always some tumors which are associated with it. And the classical one that we are seeing on the screen is the granulosa cell tumor of the ovary. And this is our friend, the Karl Exner body. I am not going to go into the histology. It was thought to be of unknown origin, but then it is supposed to be dimerization of mutant FOXL2 protein. Please remember this, and this is the reference, which you can mention as far as this answer is concerned. Another very, very rare tumor, Gonadoplastoma, is this. It is supposed to be related to the dysgerminoma. And this can be kept as a slide for us in the examination. What I'm seeing over here is a streak, that is the ovary. In fact, the normal ovary is not seen, but then there is a tumor that is developing. It is almost benign, a gonadoblastoma. The same thing over here. And the Swyer syndrome is a combination of gonadoblastoma and a dysgerminoma. In the background, I am finding a picture of a dysgerminoma, or rather a seminoma over here. And the combination of this is called as a Swyer syndrome. Neither the depth of despondency or the height of euphoria tells you how long either will last. In many a context, this can be applied even to myself. Incidentally, this is the fibroid, which can also result in hyperestenism and can be associated with infertility secondarily. This is again a beautiful diagram for the recapitulation. No delving into it further, but please go through it. Beautiful picture for us to register. The next two slides are for general reading. But then I would like you people to go through it and take down your own notes and see how many of it you people can compile. For example, there can be smoking itself interfering with ovulation. There can be an early menopause. There can be a defect in the embryo transfer. Hyperestenism, as I had mentioned. Fibrosis, secondary to radiation. Chemotherapy can be mentioned as a secondary cause. Also, you find that there can be a premature ovarian failure. This is important, something called as anti-sperm antibodies. The female will be harboring these antibodies so that it immobilizes and kills the sperm. Impaired fertilization and embryo growth. Hyperviscosity with enough mucus. Surgical adhesions. Leptin can be defective, or it can be a celiac disease. So there are at least about 20 causes which you people can very easily recollect and write at least 10 of these. It will improve our answer. Neither the height of despondency nor the height of euphoria. Tells you how long either will last. Something that is fine, and I have gone through it as well. The WHO, this is again a repetition of the same, a beautiful table which you people can draw. Adenomyosis and others. So this is a specimen. Whenever you open the uterus and it is asymmetrically enlarged, you'll have to think of adenomyosis and you'll be finding this hemorrhagic spots. I used to answer that leiomyoma causes asymmetry. It is the other way around. Adenomyosis causes asymmetry and a cricket ball-like consistency. Again, a list of causes for you people to recollect. This incidentally is a slide of endometriosis. So endometriosis elsewhere, it can occur after pregnancy or cesarean, but it can occur earlier also after inflammation, resulting in a attrition or an obscuring of the fallopian tubes. This is an important diagram as such. You might be wondering what it is associated with insulin, insulin resistance, etc. But what I am interested is there is a disruption in the early follicle development, anovulation, and infertility. This can be associated with diabetes. This can be associated with infertility. That is why this particular flow diagram is informative to us. It takes considerable knowledge just to realize the extent of your own ignorance. Again, might be applicable to me. A beautiful table which you people can memorize. It is quite simple. Kallmann syndrome is there, Sheehan syndrome is there, and all the others. Hyperthyroidism, hypothyroidism, diabetes. Please buy one. Gonadoblastoma is here. But then this particular slide is put up for the series of syndromes. I would like you people to kindly memorize this. Turner's, all of us know. So here you already see. And they can be associated with renal agenesis as well. This is Mrka syndrome. The diagram is given here. It appears a little complex, but then there is an agenesis that is seen. The causes are mentioned. The expansion of it is given over here. And these are again the various syndromes. MRKH, which means Mayer, Rokitansky, Kuster, Hauser. And isolated vaginal atresia, something that I mentioned in the earlier slide. Wanton 4 syndrome and androgen insensitivity. So these things you people can just mention if probable. This is an important cycle. You find that the flow diagram is mentioned. It can be related to the organ. It can be unexplained, or it can be functional and rare. All the boxes given here are related to the organ. For example, external genitalia and vagina, uterus, tubes, and ovaries. So the conditions are given here. Kindly go through them leisurely. And most of it you people would have already come across. You can mention. Mullerian anomalies, for example. So this again is an axis resulting in the glucocorticoids, etc. This can be associated with the Sheehan syndrome as well. There can be a pituitary hyperplasia followed by a massive necrosis. And that itself can be prior to pregnancy, or it can follow a pregnancy, resulting in secondary infertility. A word or a smile is enough to put fresh life in a despondence. Inflammation, as I had mentioned, there can be obstruction of the fallopian tubes. So I find that there is a distension over here, but there is a complete occlusion of the tube. So these are the syndromes mentioned again over here. Kallmann's and Sheehan's, you people will have to mention. Polycystic ovary, you will have to mention. And gonadal dysgenesis or the Turner's syndrome. Pituitary tumors are probable. So this is the classical picture from WebPath regarding the Turner's syndrome. I find that there is an atrophy or an atresia of the fallopian tubes, as well as the uterus and the cervix. And this is what I'm finding, a maldevelopment of the female genitalia. And these are all the manifestations. Initially, the child appears normal, but you find that when it attains menarche, there is menopause simultaneously. Your Robbins mentions it as menopause before menarche. Gonadal streaks are what I had mentioned over here. Other things kindly go through. Kallmann syndrome, a classical one, which I had explained in male infertility. There is olfactory epithelium. The migration of the senses to the hypothalamus is prevented. The hypothalamus hypophysis axis is also prevented. So is the action of gonadotropin releasing hormone, releasing, as a result of which you find that there is a gonadal agenesis. Pelvic inflammatory disease is a very common topic. All of you know these conditions. Gonorrhea, for example, trichomonas, etc. Any of the peritoneal disorders, Crohn's or an appendicitis, can result in adhesions. Also infections, particularly tuberculosis. Any intrauterine device for a long time can result in perforation, actinomycosis, resulting in obstruction and infertility. So this again is the Mrka syndrome over here, which shows undeveloped vaginal canal or vaginal agenesis. Now look at these slides carefully. There are various forms of endometrial hyperplasia. It can be simple, it can be complex. It can be with atypia, without atypia. All said and done, you find that there is an increase in the number of glands, an increase in the gland to stromal ratio. Less of stroma, more of glands. In this picture, I am finding secretory vacuoles which are present, which Ackermann used to call as secretory hyperplasia. Here again, there is an evidence of pseudostratification and well punched out glands. Those days, it used to be called the simple hyperplasia or a cystoglandular hyperplasia. All said and done, at the background of this, there will be a hyperhysterectomy. There was a very complex case that I had seen recently. A 31-year-old lady anxious to survive, presenting with complex hyperplasia and atypia. I was a little upset in releasing the report, but the gynecologist was very encouraging in giving the line of circumventive management that is probable, which we shall see. So I would like you people to kindly collect the various causes for the infertility. This is a good list worth memorizing. The good death, Pearl's book, which has won the prize that is mentioned. It is a story of a surrogate mother. And even otherwise, you find that there are multiple other panels of management, and life is not as bad as we think. And this is a beautiful movie of the same. And look at the year. In 1937, a woman volunteers to be surrogate. The Good Death by Pearl S. Buck. A beautiful novel worth reading if you come across. Thank you.